Thanks so much. Thanks for having me. Just want to make sure you're able to see my slide here. Okay, great. So I'm going to be talking about delirium and hip fracture care. But first, I want to acknowledge that the land I am living and working on today is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and the Haudenosaunee and Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis people. I also acknowledge that Toronto, which is where I live, is covered by Treaty 13 with the Mississaugas of the Credit. I think land acknowledgements are really just a first step, and I usually try to reflect on how the work that I am doing today, pertains to, where I live and sort of the historical context. This was an excerpt from a news article from CBC a few years ago, and the quote reads, "An Indigenous elder, a 72-year-old woman suffering from sepsis, was accused of being drunk. They assumed she was consumed with alcohol, who was so sick she could hardly form words, scolding her and berating her and accusing her." So I think, as clinicians, we owe it to our patients to be mindful of any biases that we have, to not make assumptions, and to really do a thorough assessment, to be able to provide the best possible care for all of our patients. So I'm going to cover delirium specifically as it pertains to hip fracture care. We'll cover the assessment of delirium, prevention, and management. When I tried to craft this together, a lot of the literature is on delirium in general, although there are also some that are specific to surgical settings. And then as much as possible, I will try to focus on where the literature is very specific to the hip fracture setting. And what you'll see here is I have three sort of color-coded indicators, and these will be on the top right hand of each slide to sort of guide you as to what the scope of the literature covers pertaining to that particular topic. Okay, so we know Canada is aging, right? We're going to see there's a lot more old people. There are a lot of hip fractures currently, about 30,000 per year. So we can only imagine the next decade or next 2 decades how many more people we'll be caring for, unless we somehow have some miraculous drug for fracture prevention. Everyone is on it. But what we also know is that delirium is very common in people who sustain hip fractures, and the literature is anywhere on the order of at least 30%. So this becomes very important from, a demographic perspective, but also we know specifically about people who have hip fracture and experience delirium are at a much higher risk for mortality, both in hospital and 6 months out. Experiencing delirium after hip fracture is correlated with a longer length of stay and therefore cost. And probably most importantly, those that experience delirium after hip fracture are much more likely to be institutionalized and discharged to long-term care compared to those that do not develop delirium. And so what is delirium? Delirium really is it's a DSM-5 diagnosis that is characterized by a change in someone's mental status. And the hallmark feature is there really has to be a disturbance in attention, that inability to go from one topic to another appropriately. And it tends to be quite acute, the onset being over the course of hours or days. And there is a fluctuating course that affects multiple domains in cognition. But most of us are not psychiatrists, right? We're geriatricians, nurses, physiotherapists, occupational therapists, surgeons, anesthesiologists. And so we don't have a whole hour to do a mental status exam, but we should be screening for delirium. So we have this example. So a 92-year-old woman presents to hospital after a non-syncopal fall that results in a right intertrochanteric hip fracture. So which of the following screening tools has the best test characteristics to determine if she is experiencing delirium? It's up to you if you want to participate, but you can feel free to type your answers in the chat, but I'm going to just proceed along. Is it the confusion assessment method, the delirium rating scale, the 4AT, the ultra brief 2-item screener for delirium? Name is not very brief, so they abbreviated it to UB2. So the confusion assessment method is probably the one that's most commonly used in Ontario, although I do see a shift towards using the 4AT. So the confusion assessment method has a sensitivity of 80%, specificity of 98%, and really consists of 4 features. You have to have both features 1 and 2, and then either one of 3 or 4. 1 being, is there an acute onset and is there a fluctuating course in their cognition? The best way to ascertain this is really to ask the family, to ask the nurses who have been looking after the patient for the last shift, to see if there's been any sort of changes in that course. The second feature is inattention. And the most important thing is this cannot be assessed by just having a conversation with someone, because that can be missed. It actually needs to be formally tested, either with, can they perform months of the year backwards? Can they do forward digit spans and reverse digit span? And then feature 3 is disorganized thinking. This is sort of the situation where you have a conversation with the patient, and if you have it, you're like, is it me or is it them? I'm not really quite following what they're saying. That's an example of disorganized thinking. And then feature 4 is altered level of alertness. You basically observe them if they're anything other than alert. If they're really hyperactive or if they're really somnolent during the day when they shouldn't be, that meets that criteria. Okay, so that's the algorithm for the confusion assessment method. The other one that's well validated and has pretty good psychometric properties with a sensitivity and specificity of 87% is the 4AT. And this one you'll see being used much more commonly in the UK and in Europe, but really also tries to operationalize that DSM-5 criteria, right? So again, there are tests for alertness, which is just based on observation. The AMT4 is basically 4 questions to ascertain, are they organized or not? Attention is done with months of the year backwards. And then again, the acute change or fluctuating course is ascertained by asking other people who have observed them over that period of time. The UB2 sounds very tempting, right? I don't have time. I want something fast. Okay, this is very fast. This is just 2 questions. It was meant to be used in the emergency department. So if your patient is coming in with a hip fracture, they're still in the emergency department, you're an emergency room physician or nurse, you can ask them 2 questions. Tell me the day of the week and tell me the month of the year backwards, starting with December. And if they get both of them correct, you can be pretty confident that they don't have delirium. But if they get one of them wrong, it means that then you should probably administer another screening tool or assessment to determine if they have delirium. So the answer would be in terms of screening for delirium, and this is not specific to hip fracture, this is in general, hospitalized patients. The confusion assessment method is a good tool, the 4AT is a good tool, and if you're in the emergency department, the UB2 is a fair one as well. Okay, so on further history, you find out that she has a history of well-controlled hypertension and depression. Her medications are only amlodipine and sertraline. She wears glasses and hearing aids. Her labs are normal on admission. She uses a cane, but is independent otherwise for ADLs and IDLs, and there were no previous cognitive concerns. So again, this is a lady who's come in to the hospital with a hip fracture. She's waiting surgery. So you're going to advise she's at low risk for developing post-op delirium. She's at moderate risk for developing post-op delirium. Oh, well, we should just cancel the surgery. This would be terrible. Oh, I'm lazy. Can't machine learning just give me the answer? It's 2025, right? Well, delirium risk stratification, why should I even bother? It's not going to change management. So again, I want you to sort of think through this scenario and commit to an answer. Okay, so what does the literature tell us? So we know that there are many, many predisposing risk factors for delirium. And in a systematic review that was published in 2023 of sort of all comers, so this is not specific to hip fracture patients, this is just patients who come into hospital, they identified at least 33 predisposing risk factors for delirium and another 112 predisposing factors, okay? But of course, in hip fracture care, what's different is that they've come in with a very big precipitating factor. That is the fracture itself, and then the prospect of needing surgery. So these are really big insults and big precipitants. So even someone who is not very predisposed to developing delirium can easily develop delirium in this context. And that's important because trauma and fractures are associated with a lot of neuroinflammation, and the mechanism of delirium in this population is different from the people who develop delirium that are admitted to a medical ward. And it's important to appreciate that because the interventions that we use to try and prevent or lower the risk of delirium is quite different in the hip fracture population. Now, for those of us that are, using, I did not use any form of AI to generate this talk. I tried and it was not very good, but machine learning has been used to develop algorithms to predict who is going to develop delirium, specifically in hip fracture care. And this was based on a data set of close to 30,000 people in North America as part of the NISQIP data set. And it had pretty good discrimination and perfect calibration. The folks have made it freely available online, and you can see that it just requires sort of 6 things known about the patient: their age, their ASA class, functional status, preoperative dementia, preoperative delirium, and preoperative mobility aid, and it will spew you out a probability of whether this person will develop delirium. But, we should be mindful that our patients are not numbers, right? Risk calculators are meant to serve as decision aids, right? Numbers, whether taken in isolation or in index, is not a substitute for clinical evaluation and clinical judgment. And a case in point is I love pointing out this particular study that was done in Ontario that looked at 35,000 people in Ontario and who had a hip fracture. And they identified that patients where English is not their preferred language had a much higher risk of developing delirium after hip fracture. And so this is what I mean by, yes, we can put people through, language processing, algorithm. But at the end of the day, you also want to look at the patient in front of you and say, are there other factors that we haven't considered? And language is particularly important in Canada and Ontario because many of our patients, English is not their preferred language, right? And so in other words, language matters, things about the person matter when we're ascertaining, is this person going to be at risk for developing delirium, right? And the reason why we try to assess delirium risk is while it would be great to implement delirium prevention strategies for all our patients, there's only a limited amount of human resources and energy. And what we want to do is probably focus on that moderate group, the group that is at risk and is potentially modifiable, as opposed to those that are at low risk and are never going to develop delirium anyway. Or even you can argue maybe the ones that are super high risk and maybe, again, the moderate risk is the ones we want to focus on. So when we decide this person is at moderate risk for developing delirium, we can't just hold that assessment in our heart, right? And say, oh, okay, well, I'm going to do something. We actually have to communicate that risk to the whole team because everyone has a role to play, right? One is the patient in terms of understanding what their risk is and being able to engage their family members on the delirium prevention strategies, which I'll show you a bit later, but also all the other team members, the nursing staff, the anesthesiologist, the surgeon, the geriatrician, the allied health staff. So in this particular scenario, she needs glasses, she needs hearing aids, she has a history of depression, she uses a cane. If you put her through the algorithms or all these other prediction rules, they would peg her at moderate risk for developing post-op delirium. And yes, you can use machine learning. My caveat is just also remember that you have a person in front of you. And so while the machine learning may be able to give you a starting point, you want to take a good history and see if there are other risk factors potentially that are modifiable. Okay, so you've decided that she's at moderate risk for developing post-op delirium. Okay, so she's coming with the hip fracture, hasn't had surgery yet. So to reduce her risk of developing delirium, you are going to counsel the family on delirium, orientation strategies, mobilization, hydration, avoidance of sensory deprivation. Are you going to ask for a comprehensive geriatric assessment? Are you going to admit this person to the geriatrics ward and orthopedics just performs a surgery? Are you going to admit the patient to the orthopedics ward and have geriatric medicine consult? Or are you going to admit them to an orthogeriatrics co-management unit? We have lots of choices here. And so I want to focus here, these are sort of non-pharmacologic things that we can do. So this is what a surgeon said. Atul Gawande, a really prolific writer and surgeon. These were stunning results. If scientists came up with a device, call it an automatic defrailer that wouldn't extend your life, but would slash the likelihood of you ending up in a nursing home or miserable with depression, we'd all be clamoring for it. We'd have pink ribbon campaigns to get one for every person over 75. Medical students would be jockeying to become defrailation specialists. Instead, it was just geriatrics. What he's referring to is the secret sauce in surgical care of older adults, and I would argue specifically very relevant to older adults who have hip fracture. And what he's referring to is geriatric medicine, where at the heart of geriatric medicine is this CGA, the Comprehensive Geriatric Assessment. So it's taking a look at the person's medical, psychological, functional capabilities, and coming up with a really holistic, multidimensional plan, right? It's looking at all these dimensions, and you can imagine that this requires a collective effort, an entire interdisciplinary team, engagement of also the family and other care providers. In other words, geriatrics focuses on the mind, the mobility, medications, multi-complexity, and what matters most, and bringing that to the forefront of hip fracture care. And when we do comprehensive geriatric assessment, specifically in the hip fracture setting, CGA results in less delirium compared to usual care, 43% versus 53%. And this is based on 4 randomized trials with a number needed to, I say number needed to treat, but it's really number needed to prevent of 11, which is a really good number. Orthogeriatric care, really that means collaboration between orthopedics and geriatrics, so a care program where both services are involved, whether one is the most responsible service or not, doesn't really matter. But the provision of orthogeriatric care models for patients experiencing hip fracture also reduced delirium. What this systematic review showed that it didn't matter whether they were admitted to orthopedics or geriatrics or they had a co-management model.
15 Cardinal Carter North.
But as long as they work together in an orthogeriatric care model, this reduced delirium. And this is based on 13 studies.
Attention, code pink, 15 Cardinal Carter North, labor and delivery.
So part of good elder-friendly care, and this is in general, this is not just for hip fractures, right? This is in general. Good elder-friendly care involves evidence-based, multi-component, non-pharmacologic strategies to prevent delirium. And at the heart of all these different trials are a few recurring components. One is making sure the patient is facilitated to move as soon as possible, in this circumstance after surgery, that the environment is conducive to sleeping well, that they are hydrated and not overhydrated, that they have their hearing and visual aids, and that they're encouraged to eat. Okay, and this time and time again, this is 14 randomized trials. We don't need to be doing any more trials on this. We just need to be implementing this. Time and time again has shown to reduce delirium with a relative risk reduction of 0.57. And when we try and just focus only on trials that looked at hip fracture care, 3 randomized trials, again, very effective when we do these multi-component non-pharmacologic strategies. Families will often ask, well, what can I do? Okay, and these are two sort of pamphlets that are freely available to download. One is from Health Quality Ontario, which has a set of quality standards on delirium, but this is a patient-facing material, caregiver patient-facing material, where you can try to empower families on what they can do, right? Cheer on grandma when she's walking, make sure that the catheter isn't in, tell them that she was continent beforehand, you know, those sorts of things. Tell grandma that, yes, you can keep walking, you can sit up in the chair for longer. And similarly, there's also a pamphlet available from the Canadian Coalition for Mental Health for Seniors. So what would be correct? Yes, you should counsel the family on all these non-pharmacologic delirium prevention bundles. Yes, they should also receive a comprehensive geriatric assessment. Number needed to prevent is 11. And they should be cared for in an environment that has a program for orthogeriatrics. Okay, so we're still on prevention, okay, non-pharmacologic, great, that stuff really works, but is there a silver bullet? Is there a pill that we can give to make sure they don't develop delirium? So,
attention,
sorry.
All clear. Attention, code pink, all clear. Attention, code pink, all clear.
So to reduce her risk of post-op delirium, you're going to A, give her melatonin for prevention, B, give her Haldol for prophylaxis, C, give her a lot of iron because she's going to lose a lot of blood and blood is good for the brain, D, give her thiamine, right? I heard that was good for the brain. E, I'm going to give her gabapentin to try and manage her pain better so that she doesn't develop delirium. Okay, so again, you can think about this, type your answers in the chat if you want to, but, you know, these randomized trials specific to hip fracture care show that melatonin doesn't work, Haldol for prevention doesn't work, iron supplementation, thiamine supplementation doesn't work, and gabapentin hasn't been studied specifically for hip fracture only, but in surgical settings, those that are newly started on gabapentin in their perioperative period have actually an increased risk of developing delirium. So the answer here is no, there's really no drugs that can prevent this lady from developing delirium post-op after hip fracture. Okay. All right, but how about the anesthesiologist? They're part of the team too, right? So again, this lady is 92 years old, comes in with a hip fracture. She hasn't had surgery yet. She's in a lot of pain. So you have to communicate that risk to everyone who's involved, which includes the anesthesiologist and the pain service. So are you going to try to advocate for a peripheral nerve block, such as a fascial block? Are you going to ask them, can you give 1 dose of high-dose steroids prior to the start of surgery? Can you use dexamethasone intraoperatively as the sedation strategy? How about using bispectral index monitoring, which I think we heard about on the last ECHO orthogeriatrics, was using bispectral index monitoring to monitor the level of sedation. Are you going to say, you know what, we have to do spinal and not GA? She's 92 and she's going to develop delirium. Or are you going to say we should just have surgery as soon as possible, forget about all this preoperative testing, let's just take you to the OR? Now, I bring all of these up because there actually have been randomized trials for each of these. Okay, so the first one is peripheral nerve blocks. So fascial blocks, femoral nerve blocks. The way I explain it to my patients, it's like kind of like going to the dentist and you get freezing, right? It numbs you, you don't get the pain. And more importantly, when you don't have pain, then you're not going to be using the hydromorphone and the morphine. Okay, so there's been a systematic review, 4 randomized trials, overwhelming evidence, such that this is really the recommendation on a lot of hip fracture quality standards and a lot of national guidelines for hip fracture care. Peripheral nerve blocks should be offered early in the course of the hip fracture journey. Preoperative steroids. This is a really interesting one. This is literature that's probably come out in the last sort of 2 to 3 years, and it's in the form of either dexamethasone or methylprednisolone. If you remember sort of a few slides back, I outlined, some of the pathophysiology of delirium in hip fracture care, right? And it's quite different from medical delirium in the sense that in hip fracture and surgery, there's a lot of neuroinflammation, right? And so if that's one of the mechanisms by which delirium develops, can steroids potentially, which is an anti-inflammatory type of medication, could steroids potentially reduce the risk for postoperative delirium? And so there have been 3 randomized trials to date that have all been in favor of using steroids. So I think this is very interesting food for thought. I'd be interested in the discussion whether any centers are routinely doing this as part of their hip fracture pathway. Dexamethasone. So, this is an alpha-2 adrenergic receptor agonist. We know that from the ICU literature, reduces pain, reduces opioids, reduces ICU delirium. When they study this in the surgical setting, when used in surgery, like all types of surgery, it reduces post-op delirium. And when specifically used in the hip fracture setting, I was able to find one randomized trial that also showed if you used dexamethasone compared to propofol as the sedation strategy intra-op, it also reduces delirium. We heard about this last week. This is processed EEG or bispectral index monitoring. It's a little sticker that goes on the forehead that tells the anesthesiologist how sedated is the patient, right? And the idea is to use this to be able to titrate to the minimum level of sedation possible that's necessary to do surgery. And so in the general surgical setting, lighter sedation is better. In the hip fracture setting, the original trial was actually done in 2010, if you can believe it. And this was done in 114 patients and showed that those that were randomized to lighter sedation had less delirium after their hip fracture repair. A subsequent study, the STRIDE trial, which received a lot of press and attention, was of 200 patients and didn't show any difference in hip fractures. But when they looked at the subgroups, the people who had very minimal comorbidities were actually the ones that benefited the most from lighter sedation. And so maybe this is sort of suggesting that maybe we need to choose our patients carefully, right? If surgery is the only sort of risk factor that they have for delirium, maybe lighter sedation is actually effective. But if they have all these other risk factors, this light versus deep sedation is probably just a drop in the water and doesn't make a big difference. Time to surgery. If all I know is if I had a hip fracture, I would probably want my surgery sooner than later, right? I don't want to be in pain. And during that time I'm in pain, I'm getting all these other drugs that have all sorts of side effects. So the hip attack trial was a multi-center randomized trial where people were randomized to either getting surgery quickly, which was 6 hours, or usual care, which was on the order of about 24 hours. And this is specific to hip fracture. And lo and behold, those that get to surgery sooner have less delirium. Okay, so what can you do when you speak to the anesthesiologist for this person who's at moderate risk for developing delirium? You're going to ask, would a peripheral nerve block be feasible? I'll leave it to you, but dexamethasone I heard works great. What are your thoughts on steroids? For this person who has some other comorbidities, maybe processed EEG may not make too big of a difference. But yes, let's just get this person to surgery. Okay. So despite your best efforts by you, the team, and the family to do all these things to prevent delirium, she is disoriented post-op. She's a bit restless. She's forgetful. Sometimes she's a bit tired and somnolent. So she has delirium. So to manage, are you going to give her Haldol, lorazepam, rivastigmine, clonidine? It's a trick question. So what you're going to do is you're going to look for underlying causes first, right? Delirium is not a symptom. Delirium is a symptom. It's not a diagnosis, right? So you're going to take a very thorough history, look at the medications. Are there any sort of potential ones that she is withdrawing from, or they're medications that we've given or are continuing to give that are not good for her brain. You're going to do a thorough physical examination, look for constipation, look for urinary retention, look at the surgical site for infection. You're going to do some screening blood work. And because she's post-op, you should also do an ECG and troponin to make sure that we're not dealing with myocardial infarction after non-cardiac surgery. And then plus or minus cultures, imaging, looking for, pulmonary embolus, DVT, based on your clinical history and physical exam. Okay. And really the tried and true is what worked for delirium prevention should still be continued to be carried out for delirium management, right? So that attention to sensory, cognition, hydration, mobility, sleep. And what we know from all these Cochrane systematic reviews of randomized trials is that antipsychotics do not shorten the duration or reduce the severity of delirium. Benzodiazepines don't work either, and neither do cholinesterase inhibitors nor clonidine. So the answer to this question is address the underlying causes of delirium and continue to persist with those multi-component non-pharmacologic delirium strategies. Okay, but now she's becoming combative and she has paranoia that's interfering with the provision of medically necessary care. So you decide you are going to give her risperidone 0.5 milligrams BID. Her ECG looks okay. You counsel the family that atypical antipsychotics increase the risk of death, stroke, extrapyramidal symptoms, somnolence, or falls. The answer is all of the above, right? So we have to be mindful that when we use these, the words I use when I describe this to families is we are using this as a form of chemical sedation to be able to facilitate medically necessary care, that they're not without these risks, okay? Lastly, the patient worries that the delirium is not going to improve and that she will develop dementia. Okay, so what are you going to advise about the cognitive recovery and trajectory and her prognosis from a cognitive perspective? So the literature tells us that in general, okay, when we look at all patients that develop delirium in hospital, this was a meta-analysis of 23 studies of close to 10,000 patients, is that patients who experience delirium in hospital are 2.3 times more likely to develop cognitive decline in the long term, defined as 3 months and beyond, compared to those that did not develop delirium. And if we look specifically at the surgical setting, and this is an ongoing cohort study that's out of Boston, the SAGES cohort, which looks at elective surgery, so not hip fracture surgery, but elective surgery, is when we look at data from 3 years, which is the one on the left, and data all the way out to 6 years, is you can see that those that experience delirium improve usually around and plateau around the 2-month mark. But if you look at the slope of the decline afterwards, in those years after that index episode of delirium, the decline in those that experience delirium is much more steep than those that did not develop delirium. So what you can counsel the family is, well, cognitive recovery may plateau after a few months. So if you're just seeing them at 2 weeks, you can assure them this is not the best they're going to be, right? They're going to continue to improve. But by about 2 or 3 months, that's probably the peak of their improvement. But also the fact that she's had developed postoperative delirium, she is at risk for future accelerated cognitive decline. And for that reason, should probably be followed regularly for cognitive testing and a history, et cetera. Okay. So if I were to summarize, what would high quality delirium care in hip fracture care look like? There would be an embedded delirium risk stratification tool, whether that's a machine learning tool or another validated risk stratification tool. This way we can direct our resources to those that would most likely benefit. There would be routine screening for delirium throughout the entire perioperative course using either the CAM or the 4AT. We would be counseling routinely their family and care partners on what delirium is and the prevention strategies that they can also help with. There would be the provision of multi-component delirium prevention strategies throughout that perioperative journey. The care for hip fracture would be embedded within a robust orthogeriatric program that has access to comprehensive geriatric assessment for all older patients with hip fractures. Everyone would have early access to a peripheral nerve block as part of the multimodal pain management strategy. Unless they are on anticoagulation, everyone would go to surgery as soon as possible, ideally within 6 hours. In the OR, the anesthesiologist would take that information about their delirium risk and be able to tailor whether this person should have one-time dose of steroids prior to surgery, whether they should be using the bispectral index monitor to titrate to lighter sedation, and whether they should be using dexmedetomidine as a preferred sedation agent. And if they develop delirium, this patient would have access to cognitive testing postoperatively in follow-up. So I also wanted to put a plug in. I know we're focusing on hip fracture, but similarly, Ontario Health also has a delirium quality standard for your reference. And as well as part of that quality standard, there is actually an implementation toolkit, which looks at how to actually implement change concepts in terms of resources, change ideas, and how you can measure that change. All right. Thank you very much.
Thank you so much, Camilla, for that tour de force on delirium. That was wonderful, and there's definitely things that I've jotted down here as well. Ellen's just put a note in the chat. I just wanted to highlight as well that it is World Delirium Awareness Day on, I think it's March the 12th. So there will be many events that are going on across Ontario and across Canada and across the world, actually, focused on delirium prevention, management, and care. One of the things that will be happening is that there will be a webinar through the Waterloo Wellington Regional Geriatric Program, and you can find the link for that below. And I reach out to your hospitals as well, because many of them may be doing their own individual events too. So I just wanted to open it up to the audience to see if there's any questions that we have for Camilla on any of those pieces that she was talking about. Please feel free to put your hand up. Morgan.
Hi. Yeah, I do have a question. So I was wondering actually, because I've encountered this a few times recently with patients where we largely deal with hip fractures here on our orthopedic ward, and we do manage a lot of patients that come incidentally from nursing home facilities. The capacity for these patients to remain inpatient after surgery, is limited. We have some geriatric support, of course, but ultimately, to be able to manage these patients and clear the delirium fully and offer all of these things, it is not entirely feasible. And we do sometimes have to have them return home, like to the nursing facility for ongoing support, just as it goes. And I noticed that from the family's perspective, this sometimes it's met with a bit of resistance, understandably, because they're concerned and they don't understand always why the patient isn't the way they were when they left the facility and how long are they going to be like this? And they have all these kinds of questions. Yesterday, I actually was telling my manager, I think we need like a narrative or a script that we can almost apply to all of these circumstances so that everybody kind of understands like what to expect and maybe how we can eloquently distribute this information to families so that it's better received in terms of, the delirium may take a long time and sometimes does not always come back to baseline at all. So just thoughts on that if anyone has anything to add. Thanks.
Yeah, no, thank you for your comment. So I think it's good that now we actually have literature, at least from delirium in general and delirium specific to elective surgical populations about the trajectory, right? It really is on the order of months in terms of recovery, and then sort of at that 2-3 month mark, the recovery plateaus. And so that timeline, it's not just a number that we're making up, it is really a number that has been observed in, a lot of these cohort studies. In terms of, counseling the family, I did point out that Health Quality Ontario or Ontario Health has that information pamphlet on delirium that is meant for patients and caregivers. I can't remember off the top of my head if it talks about the duration of the delirium. I think it mostly focuses on strategies to prevent, but and strategies to manage. Speaking to the concern about, they're not the same as they were, and now they're going back to long-term care. One of the things that I usually try to convey to them is, if they've been at long-term care for a long time, it's actually the people at long-term care, the care providers at long-term care probably know that person a lot better, and they're able to, care for that person with that person-centered or focusing on that personhood aspect of delirium management, as opposed to in acute care where, they get a new roommate every day, they get a new nurse every day that really doesn't know them, et cetera. And so that's one of the ways I try to frame as to why, once they are medically stable and they're recovering from a surgical perspective, returning back to long-term care, as long as they're sort of eating and drinking and they can meet their needs, is actually better.
Thank you.
Camilla. Oh, Victoria, you have a question?
Yes, thank you. So we are trying to include a delirium project on our SWIP related to hip fractures. So our change idea is to add an automatic geriatric consult for all 65 plus patients coming in with an operative hip fracture. The concern is now, is this going to be a capacity issue for our geriatricians, because that's a huge influx of patients that they might not have otherwise seen. So I was wondering, for you guys who have this as a kind of a part of your routine practice, was there a transition period that was difficult? Was there a best way to manage it?
I think the main thing is you would need to engage the geriatrics group to see whether they could service that volume. I'll put a plug in for advanced practice nurses. I mean, are an alternative way of meeting this need. And I think a lot of hospitals have gone towards that when there aren't enough geriatricians. So again, an advanced practice nurse that has special training in geriatrics and focuses on hip fracture care can provide very good, high quality, comprehensive geriatric assessment in that focus setting, with backup from a geriatrician if the cases are a bit more nuanced or unusual.
Thank
I'm
you.
just gonna second that, because that's exactly the model that we had with Kayla, who was our nurse practitioner on our ortho unit. So when those automatic consults came in, Kayla would be the person who did it. And I would actually say that I think it's a better model because there's continuity of care, as opposed to some consult service. The geriatrician or the physician may change every week. The families are speaking to different family members, and that continuity of care of being able to see multiple times a week and having that consistency of communication is very important. I would say that when we started this, like, we were an engaged group to begin with, but just being able to find the numbers that you have per year. So we're a regional center. We take from, all over Southwestern Ontario for hip fractures. And even at that capacity, we have about 200 to 250 hip fractures per site per year. So that equates to less than one a day. And when we presented it like that to our geriatric colleagues, it suddenly felt much more doable than saying, oh, we're going to see 500 people a year. So that selling it that way may be helpful. And I think the third thing that I want to say is a lot of these patients who are at high risk of developing delirium, we would much rather see them early and see them not get delirium than see them 10 days post-operatively when they are in the throes of a severe delirium and have been deconditioned and unable to participate because of their cognition. And it's actually a fairly satisfying thing to do, to know that this person is actually doing well. And the fact that they haven't had a complication is down to the work we've done. So I would very much advocate.
Thank you so much.
Any other questions? Trish.
I have to remember to take myself off mute. So I have a kind of an extension of that question. In lots of areas of the province, there often, but not always, is access to a geriatrician in the hospital setting. But when we're talking about sort of extended follow-up, there's a lot of follow-up. We put a lot of focus on bone health, and of course, ortho, we put a lot of focus on the fracture healing or the prosthesis being fine. But I think that Dr. Wong's point about following people who have had delirium in the community, sort of, and keeping an eye on that, like that kind of follow-up, what would you suggest? Is that, like, especially in areas where you don't find a lot of geriatricians in the community or where they might not be embedded in a family practice?
Yeah, I mean, I certainly don't think that the follow-up needs to be with a geriatrician. I think the what the literature is showing us is that if you develop delirium, you're at high risk for developing cognitive impairment dementia down the line. And one is the family should be made aware of that so they can look for the signs and symptoms. But certainly the follow-up could be done through primary care, again, provided that they have a primary care practitioner to be able to do that. And usually like my standard statement that I have on, the discharge summary is, this person developed delirium, and I sort of quote why they need follow-up, but I recommend that they have, an assessment at 6 months with formal cognitive structured testing through their primary care provider. That's sort of my generic statement. And then obviously referral to, specialized geriatric services if there are concerns.
That makes sense.
I think we're going to need to move on to the cases soon, but Camilla, can I ask you one last question? Just because our institution is going through the entire CAM versus 4AT, I can't tell you how many meetings I went to about that. Would you be able to comment at all about the amount of training that's required to administer the CAM versus the 4AT? If we're going to be adopting it as a training tool for the institution or the specific unit?
I mean, I can only speak experiential. I think the fundamental problem with the CAM is that unless people are actually testing for attention formally, and I think that's where things just slide. People just say, oh, attention, and, oh, okay, I'm just having a conversation with the person, they're attentive. I think that's why the CAM is not as successful in real life. Whereas the 4AT it's very prescriptive. It actually says, like, ask these specific questions. The alternative is to use the 3D CAM, which also has very prescriptive, like basically a script of what you're supposed to ask. But I think in terms of training time, they're probably about the same. But I think in terms of fidelity and sticking to how it's intended to be used, the 4AT probably has better fidelity.
Great. Thank you so much. And thank you for taking the time to come and speak to us today. I really enjoyed that talk. And I think the one thing I'm going to take away from this is I'm going to try to do that machine learning thing and play around with it.
Yeah, I know no one asked me the question, but I'm curious if anyone wants to reach out to me, if anyone's doing the steroids at the time of surgery induction. I'd be curious to know if there's any centers that have moved towards doing that.
Great. Thanks so much.